Hello, good evening. Welcome to the Health Scrutiny Committee. Present at the meeting tonight we have Councillor Paul Warburton, Councillor Jean Carter, Councillor Steve Wright, Councillor Ian Marks, Councillor Judith Wheeler and Councillor Tony Williams. Also present we have colleagues and officers from Warrington Borough Council and from partner organisations throughout the service. I'll hand over to the Chair now to formally open the meeting. Over to you, Chair.
Thank you very much. Do we have any apologies for absence at all?
Yes, Chair, we've got apologies from Councillor Pat Wright and from Councillor Sarah Hall, with Councillor Steve Wright substituting.
Thanks very much. And do we have any declarations of interest that anyone would like to declare at this point?
Councillor Warburton Paul, Steve Wright, Councillor Wright. My wife is an employee of Warrington Hospital.
Thanks very much for that, Steve.
Chair, it's Councillor Wheeler. This may come up under item 11, the North West Boroughs Partnership. So I'll declare it now. I'm actually employed by Mersey Care NHS.
Thank you for that. Thanks, Judith. Okay. Everyone else happy? Okay. If we go on to the minutes of the last meeting, does anybody have anything to confirm or any additional comments to be made on those? I won't go through them page by page, but can somebody propose those as okay?
Move the minutes, Chair.
Does anybody like to second those?
I can second those, Councillor Carter.
Thanks very much, Jim. So that brings us to agenda item number 4, which is the Warrington Together update. And is that Simon?
Thank you, Chair. Apologies, colleagues, that I haven't submitted a written report. I just wanted to cover 3 issues very quickly. The first is around integrated community teams, and you'll be aware that they're operational in Alfred and in Great Sankey. We're working hard to learn the lessons of COVID to see how we can work more remotely and to share information more remotely. The second issue was around the People's Panel, and I'm sure Lydia might want to say something, but we've got at least 250 individuals who are part of our People's Panel who can engage with our plans for going forward in terms of Warrington Together. And we've just recently, if you've read the local paper, tried to engage and encourage people to come on the People's Panel. And the third thing is around social prescribing. So Warrington is blessed with having lots of voluntary sector organisations who can improve people's well-being, and we're just preparing to encourage a whole culture of encouraging social prescribing, not so that councillors, when they identify constituents who have some problems, rather than refer them onto NHS organisations, can actually refer them onto voluntary organisations to improve their well-being. So that's my 3 areas, Chair. I'm happy to take any questions.
Does anyone have any questions for Simon?
Yes, Chairman, it's Ian.
Okay, go ahead.
Okay. So can I speak?
Yes, sure, fire away.
Sorry. Yes, no, thank you, Simon. You mentioned that the 2 integrated hubs are up and running at Alford and Great Sankey. And I know that in the east, I think sort of things are happening. We've had this discussion before about the south and where it might be. Now, I realise obviously times have been difficult in recent months, but have we made any more progress on on the east and in particular on the south, which is obviously of interest to myself?
Right. Thank you, Councillor Marks. We've identified a number of sites. Our principles are to work outside of traditional NHS or social care environment. So we're looking at Broomfields, but we're also, I guess would say, aggressively looking at other sites within the south, but we've been unsuccessful I think, at this time, but we are still looking.
Okay, thank you.
Does anyone else have any questions for Simon? Okay. Simon, do you have a date on when you may have a hub in the south?
We don't at the moment. We have a work stream looking at integrated community teams, which is run by Sarah Quinn from Bridgewater. So we have, I'd say we had dedicated work stream, but we don't have a date. But I'd work with Councillor Marks around a potential suitable venue. It's been a particular difficulty in the south, as I know Ian understands.
Okay, thank you. And any more questions for Simon before we move on? Okay, thank you. Which brings us next to the public health update. And is Thara with us?
Hello, yes, thank you. Sorry I haven't put any slides together. I'm going to walk you through some of the COVID current situation. I hope that's okay, Chair. I thought that was probably the most pressing thing that people would be on people's minds.
Yes.
Okay. So I can answer any questions, but it's important for people to sort of be on the same page. So currently, as you will know, we have local restrictions in place in Warrington. They also are the same restrictions that we have in place in Holton. And as you know, our health economy is very much, we work as a pair. So what I'm about to tell you is not news to you, but it probably will help you to understand the spread. So I'm hoping to just give you a picture of the infection rates where we were and where we are now, and walk you through what the local restrictions might mean for us and what next. So 4 weeks ago, we were in a very different position in Warrington. We had one of the lowest incidence rates in the whole of the Northwest. It was genuinely low. So we had our 7-day incidence rate was less than 10 per 100,000 in each borough. So if you looked across the picture of Warrington, there weren't that many cases, and there were lots of white on the map. However, and the picture in terms of tests, there were about roughly about 400 tests being carried out a day across Warrington and Holton, and there were about 200 per day being carried out in Warrington, and we had what was called a positivity rate of less than 1%. That's very low, and our hospital admissions per week were approximately 3. So a very low picture. Then what happened? Within 4 weeks, we are in a situation that has escalated significantly. So our current 7-day infection rate, if you think back to what it was very low. Our current infection rate is over 150 per 100,000 over a 7-day period, with a positivity rate of 10%. So whereas we were 4 weeks ago less than 1%, we're now just over 10%. And our hospital admissions, unfortunately, have increased. So they are roughly about 24 over the last 7 days. This was the data that we had towards the end of the last week, and that's grown since. But I think Simon will update on that if asked. You can see that we have actually some outbreaks, community outbreaks happening. Some of them are quite high profile. They've appeared in the Warrington Guardian, and some of them our team have been supporting the businesses, the areas that are experiencing outbreaks, in order to to make sure that we contain them and stop the spread. If you look at the picture of age groups, it's no longer the 20 to 39-year-olds that are being affected, it's the older age groups as well, and that is of absolute concern. Whilst it was the working age population, you know that in general terms that doesn't translate into hospital admissions and fatalities, whereas we're seeing a spread now amongst the older age groups. And I'll mention Holton, even though this is about Warrington, but we're seeing the spread across both areas as well. So if you're thinking about our testing has gone up. That's the both pillars, pillar 1, which is about outbreaks, and pillar 2, which is about things like the whole care home testing and those sorts of things. So we have actually got quite good data about the positivity. So we can tell that it's not just because the tests have increased, the numbers of tests. It's much more than, well, our infection rate could be explained by the fact that more people are getting tested. That isn't the case. In terms of what's happening in Warrington, we are actually you could say that we're actually in absolute numbers in a slightly worse position than we were during the March-April times. That isn't to say we haven't got the hospitalisations and the deaths that we had at that period. I could only say that it's a matter of time, unfortunately. We have some, so just to conclude, it's spreading fast. The pattern was in working age, but this is changing. It's across different age groups, especially the older as well. There is some evidence of more serious illness and transmission to more vulnerable groups, which has unfortunately given rise to hospital admissions. We have identified transmission from the hospitality sector, but not exclusively from the hospitality sector. There are cases in schools, many of you already know this, and there have been a small number of outbreaks of more than 2 cases, which has resulted in a significant number of our teachers and pupils having to self-isolate. Businesses are managing a very, very difficult situation. They've been doing it extremely well. They've put their risk assessments together. They're being as COVID secure as they can within this current climate. And we are working with them to manage a number of outbreaks. In terms of the retail sector, there have been a small number of outbreaks, and you've probably seen in the paper that there is one particular supermarket that's been affected. In terms of the hospitality sector, as I mentioned, there has been a large outbreak in one of the pubs, which was documented in the media, and with possibility of onward transmission as a result of that. And if you've read my comments about that, I'm not sure what that establishment could have done, because it was somebody who was showing no symptoms. So that is problematic. So that's the picture in Warrington. In terms of an action plan, Warrington is on the watch list, hence it then went into local restrictions. On a regular basis, the council, through me and Stephen Bream, had produced a Director of Public Health narrative report in order to summarise what's happening in Warrington, where the challenges are and what could be done differently. We've produced an action plan of a communication strategy, but the whole picture is evolving very quickly. So we have a whole system approach that is needed, and so all of us need to step up, and we are in this escalation position. So some of them, and I don't know how easy it is to actually understand what's national, what's Warrington, and what's on the horizon. But essentially, we are, since the 22nd of September, in Warrington, we're not allowed to socialise with people in our own households, except for when they're in a support bubble, including private gardens. Table service only for food and drink in this hospitality sector. You will have heard about the restrictions of 10 p.m. to 5 a.m. for a variety of leisure and entertainment and hospitality sectors. And they are in law, they are legally enforceable. We do also have additional advisory guidance for Warrington that isn't legally enforceable but strongly advisable. So that is to only use public transport for essential purposes such as travelling to school or work. And the other one is avoiding attending amateur and semi-professional sporting events as spectators. Now they're advisory, and we are querying the second one because we think that that's probably not going to be particularly helpful for some of our younger, sporting events, possibly from a safeguarding point of view. So we don't want, we don't want lots of parents turning up for, to watch their kids on the sidelines. But actually, if one parent wasn't allowed, there might be some safeguarding concerns. So that's something we're querying locally as well. I'm going to stop there. Chair, do you need any clarification or are there any questions, please?
Oh, that's fine. Does anyone have any questions for Tara?
Yes, Paul.
Okay, go away.
Yeah. Thanks for that, Tara, for that clarification. I mean, one thing I think is a little bit confusing. I thought, perhaps I think wrongly, that we were in quote local lockdown unquote. Then I saw your quote in one of the papers saying Warrington is not technically in local lockdown, and you just used the phrase there are local restrictions. So although I know you're doing your best and it is difficult, I do feel there's a little lack of clarity. I mean, another thing, for example, you talked about sport. I mean, I play tennis. I mean, I'm not sure whether I'm allowed to play tennis with a limited number of other people or not. We did for a week or two, but I mean, I thought at one time we couldn't. Perhaps we can now. So I think there are various grey areas like that, and people visiting outside the borough. Is that the same as people not visiting within the borough? Little things like that that people are a little unclear about. So although you're doing your best, I just think we need a little bit more clarity on some of these slightly more grey areas. Thank you.
I completely agree, and that's why on the council website, because it's not just those questions, there are numbers of questions that people have. We've got a growing number of question and answers on the council website, and if it's still not clear, there's that Contact Warrington email address to be able to sort of try and unpick some of this, because it absolutely is confusing.
Okay, thank you.
Thank you. Does anyone else have any questions at all? Tara, do you see that the restrictions that are being asked on the population of Warrington are actually being observed by the residents and the people going out socialising into hospitality places? Yeah,
it's a helpful question. I think we're no different to any other area. I think my observation is that people in Warrington are very well respect each other. They do understand what they can and can't do, and are doing level best. I think there are some exceptions, and when there are exceptions, usually somebody will tell them, and that spirit of Warringtonness, I think, is really helpful, and it'll get us through, rather than sort of reporting people to the police. There seems to be a sort of, a nudge a nudgeness about Warrington that I think will be helpful. But unfortunately, occasionally people do get a bit out of order and a bit, get a bit carried away. And we have identified some hotspots and are working closely with different partners to address those hotspots where we've observed it being a bit more difficult to socially distance and all of that. But I just wanted to say this is not because we're not in this position, I don't believe, because Warrington can't behave ourselves. This is a question of inequalities. And that's the picture I'm seeing across the northeast and the northwest. It isn't because we don't know how to behave or we're not following social distancing or the rules. I see this as a matter of inequalities.
Could you
exacerbated?
Could you expand upon that? And how do you mean by?
Well, I think that there is generally a level of inequality across the north of England, when an issue like COVID comes, it exacerbates those inequalities.
Yeah, I agree. Yes, thanks very much, and welcome to Health Scrutiny. Is this your first meeting?
Chair.
Thank you.
Chair.
Judith?
Sorry, it's Councillor Wheeler. Sorry, I forgot I was on mute before. I just wanted to ask, sorry, before we finish this, ask Tara, could you just repeat what she was saying about amateur sport for children? I'm trying to write it down and I'm not quite sure what. I know she said we were sort of there were concerns. Just wondered if she could repeat what she said about that.
Yes, I'm happy to. It's still work in progress.
Yeah.
The restrictions came in only last week, so we are just querying whether it should be a blanket advisory statement for all age groups, or whether it should actually just say for children of a certain age, and we're thinking 18 and under, unless you've got particular vulnerabilities or inequalities, and maybe extend that to 25. So that's work in progress, that we're looking at whether we can advise something different for those age groups.
So is that to restrict?
It's not so this is the difficulty. That's an advisory piece of guidance that's come down from the national team. So we can either enforce it or promote it, or say, actually, we don't think that's a particularly good idea for our population. It's not going to necessarily work, so we're not going to promote it. But rather than sort of give you a chapter and verse at this meeting, if you just allow me to go away, work with colleagues to work out what our advice would be for colleagues in Warrington.
Okay, thank you. Yep.
Thanks, Judith, and thanks once again, Tara. Thank you.
Thank you.
Thank you. So that brings us to item number 6 on the agenda, which is the Warrington CCG update, and I think Andy Davis is here.
I am, Chair. Thank you very much. There are 3 short papers under this item, so rather than everybody listen to me drone on about them, I thought it would be helpful if we perhaps took them as read, and I could take questions on each paper in turn of any detail or clarity, and anything anybody wanted to know, if that would be helpful. And also worthwhile stating that through the first phase of the pandemic, it's been an absolute privilege working with everybody, and to see the partnership and camaraderie that's come out of addressing this and building on the sort of work that we've been doing for a number of years. It's been a privilege to see. And I know that partnership's going to be tested again in short order with obviously following up from what Tara said and the pressures that are mounting. So yeah, I just thought worth acknowledging that, given that we haven't had a chance to be together at Scrutiny for a while. So with that, I will happily accept questions on each paper in turn, or all papers collectively, however people wish.
Thanks very much, Andy. Does anyone want to ask any questions at all to Andy on the 6A, which is the CCG response to COVID-19 pandemic?
Councillor Warburton, Councillor Wright.
Okay, go ahead, Steve. Thanks.
Hi, Andy. I'm just thinking what the presentation we had previously is not the best defence, clarity. You know, the mixed messages. I know the health professional had said that it was confusing all the time. The messages were confusing. Why is it? Why does it have to be confusing? And what's going wrong that we're having to interpret and reinterpret guidance or advice rather than just be able to say, right, we know what we've got to do now. We can get on with it. Why is there a lack of clarity about these things? Not so it's you, but it's a general thing that comes through with people asking me. Where you say one thing, but you say another. Why can't we just have a clear guideline? What is going wrong generally?
It's an interesting one, and it gets into the realms of a bit of opinion there. So I'll be careful in answering it, because I think everybody's got a really challenging job in how those things are communicated. So ultimately, the goal, I think, is to help minimise spread and keep the level of the virus in a low level. And one of the only mechanism really we've got to do that at the moment is reduce social contact. So that's been the approach that's been taken. I think then what happens is that drive to reduce social contact becomes a series of examples, which then become perhaps recommendations or legislation that all start to reduce our time together in social contact and reduce the opportunity for the virus to spread. So going from that general principle of reducing social contact to drive down the circulation of the virus, we're getting into a lot of complicated rules, and almost, I think, because there's reasonable questions that people put forward, rather than accepting the principles, we're ending up with lots of very fine rules that say, well, we can do this and can't do that, and then we overlay different sort of sectors on that, and it becomes even more confusing. But I think if people keep in mind that the goal of all of that is to reduce social contact so that virus doesn't have as much opportunity to spread, that's the most important thing.
Okay, Steve, happy?
Yeah, I just think there seems to be a lot of oversteer. I think we seem to go one way and then all of a sudden we've got to reverse and go back the other way rather than steer a steady course through. And it just seems a bit mixed, and it's important we get it under control. Thank you. That's it, Andy. Thank you.
Does anyone else have any questions to Andy regarding the COVID pandemic? Okay, which brings us to the CCG mergers. Does anyone have any questions regarding that? Perhaps before we ask the questions, Andy, I know we're taking it as read, but could you give us a brief resume of the likely impact of the mergers and what's being proposed?
That's a tricky one to answer, Paul.
Well, I like doing questions like that. It's good.
You do. You and I'm happy to try and answer. So Cheshire and Mersey is our region, or sub-region, if you like. So we've got North West is the region in the NHS. The NHS has a policy that, as the paper expands upon, that there is a view that there should be a series of integrated care systems. And for us, that will be Cheshire and Mersey, that will have one organisation per ICS. So that will be, in effect, one CCG per ICS. Now, that would require some significant changes, and there hasn't really been any detailed conversation of what that might look like. The conversations we have been having with regional colleagues and the Health and Care Partnership is, how do we strengthen what we do at place by building integrated commissioning in Warrington or other boroughs that need that, so that we can build on our place-based relationships to get the bulk of the work done that needs to be done in terms of providing for the health and social care needs of our population. And that is accepted as a good approach. And I think that the concept is that whatever's then left to do at a regional level is relatively thinner, and was described as a thin CCG, as it were, and that suggests to me that the bulk of what we do now needs to continue to happen in Warrington, and there will be some other things that, in order to interface properly with the NHS broader, will need to happen. And so it's at that stage. I think there's an awareness that there's lots of different opinions on how to make that work, and lots of different people pulled from elected representatives such as yourself through to organisations that will have a view on how best to make that work. So there's definitely a conversation to be had, but that's within the context of the NHS broader regulatory environment of needing to make sense of some of this. And I think there's been an article in the HSJ today which expresses some of our leadership's thoughts on the matter, but I've not had a chance to digest that one. So there may be other things in there that have come out.
Yeah, that's very useful. Thanks, Andy. Does anyone have any questions at all on this this proposal? None at all? Could I ask another one then, Andy? Do you think that these proposals will actually strengthen Warrington as a place, or do you think that it has the potential, if we don't manage it appropriately, to dilute the placeness of the current arrangements that during COVID have seen the real benefits of having place?
I think that there are risks with any change, aren't there? But I think we've got good relationships and ways of working locally that between us we can design something that really works. And the strength of that will be that it will be very Warrington focused, but it will deliver what it needs to do for those broader relationships that we have through the national part of the NHS, that will provide assurance about the outcomes that are being delivered for the people that we serve. So I think if we carry on in the direction that we are, and we continue to work together in the way that we are across sort of like the local authority partners in the providers, so North West Boroughs, the hospital, Bridgewater, and the good third sector community that we have, and voluntary sector, I think we'll come up with a good solution that is very much Warrington, but will also be able to meet the needs of the broader NHS in terms of the assurance that we need to provide that we're making good use of national public money. So, in answer to your question, there are risks, but I think we're up to the challenge locally, and we'll make it work.
Okay, thanks very much for that one. Anyone else have any questions before, if I move us on to 6C, which is to do with the primary care networks and just the update on that? Any comments at all?
So, Chair, would it be helpful to just highlight a couple of things that I think we've had previous conversations on, which might be of interest?
I think that'd be great. Thanks, Andy.
So on the additional roles reimbursement scheme, we've had conversations before, and it was mentioned earlier about social prescribing, and that's at point 5, paragraph 5. And the primary care networks are very much on with that recruitment and fleshing out the additional roles, and social prescribing you'll be glad to hear is part of that. So the funding has gone through the NHS regional mill, because these are all part of a DES, which is a direct enhanced scheme, which basically means that it's centrally funded against a set of criteria, and the networks have to satisfy those criteria to draw down the funding, and we've been successful in maximising the opportunity there to get investment in these additional roles for Warrington, and that's to the credit of the primary care networks and how they've worked in partnership with CCG and others to get those cases made, so that we should be seeing that expansion come through. The money is due to be allocated this year, as with everything. As with a lot of other things, there's been a bit of a hitch due to the COVID response that people have had to make, but there's still a plan to get that money and resource allocated so that we can have the benefit of those additional roles, and even more important at the moment. And then I suppose the other bit in terms of the networks themselves, they're getting significantly more responsibilities around extended access and enhanced support to care homes and other things, which again we're working really hard to help smooth the transition, but it is a huge challenge. So I'm sure any offers across our partnership to help support the networks will be gratefully received. So that work's ongoing, and that's detailed at paragraphs under 6, which I think that's a significant change in how things work, and we'll need to keep our eye on that one. Sorry, that is my notification alarm going on.
Paul, can I ask a question?
Certainly. Go ahead.
Andy, it's Jean Carter. Can I just say, how can we show that the PCNs have improved patient experience, and how do you expect to show that in future?
So there are measures within the DES that allow that reporting. The first phase has been more building up the maturity of the networks to be able to respond to that. So the evaluation of how that's working comes through under the reporting mechanisms that have been agreed. So up to now, the networks have come back to the Primary Care Commissioning Committee at the CCG to sort of account for what they've been up to, how has things been going, what development needs have they got, and what are some of the successes they may or may not have had. And they've been doing that quite well to the satisfaction of the independent chair there. And it's not yet at the level where we're seeing patient outcomes, but there are some patient experience measures in there, but that's not shifted yet because it's still early in the development, believe it or not, despite the amount of time that we've been working.
Yeah. Okay, thanks for that.
Anyone else have any questions? Annie, just regarding the social prescribers,
Yes.
Will they be recruited locally will they be individuals, or will they be commissioned from an existing service? Could you just clarify that? Do you know?
Because they're additional roles, the way that they're funded, they have to be recruited to the networks. So they will be recruited locally. Now, sometimes there might be hosting arrangements for those if it's easier to do that at scale. But that will be down for the networks to determine how they do that, and we'll support them in making those decisions. If they wanted to go down the route of a hosted service, for example, then they have to comply with procurement regulations, which is actually quite a big undertaking. So it may be easier to go down the recruitment route. But again, my understanding is that they've identified the level of resource that they need for each network in accordance with the guidance documents about what's permissible in additional roles, and they're looking at a way of recruiting those to the networks for the social prescribers and some of the other practitioners. But they're doing at scale some of the things around pharmacists, pharmacy technicians, because of the nature of the work that they deliver.
Right, okay. And of course they'll engage with the existing services that are across the town just to enhance those further.
Yeah, I think they've had quite a lot of input actually from sort of partner agencies, and they did have some input into one of their meetings from the voluntary sector as well about what they could offer.
Right, okay. And as regards the care within care homes and the clinical leads around that, has that been instigated now? No,
so they have to pick up the responsibilities from that, as it says in the paper, from the 30th of September. So it starts to transition over, ready to be all singing, all dancing by the 1st of April. So we're into that cutover period. We obviously had the care home support offer in place anyway. So some of it is about transitioning that, but also improving it as well, because we're aware it wasn't quite right and didn't quite meet everybody's needs. So that process will be happening slowly over the next 6 months. Obviously, still there are constraints there in terms of responding to further waves of pandemic, but that is the timeline that's been laid out in the DES, that transitions over from the 30th with an implementation to the full specification being available in April.
Right. And the weekly ward rounds and the like, will they be virtual or will they be face to face?
Depends upon the model and obviously the status with COVID, but I think it will be a bit of a blended approach. So obviously not every patient gets seen every week, but there'll be weekly contact with the care home and a prioritised list of patients and residents to be seen, as it were. and that way work through. So it's not that everybody gets seen every week, it's on a weekly rotation, so that everybody's getting a regular review on that weekly meter, obviously with the ability to respond in between to any emergent needs.
And I have one last question for you. Just regarding the e-consult that was brought in earlier this year, which at the time seems to be quite a new bit of technology, but I think it's just now accepted as the norm. And I'm just wondering how it's going from a GP perspective, but also perhaps from a patient perspective. Do you have any thoughts on that?
So I think it's been quite well accepted by patients. We've had positive feedback about accessing the device, getting a response to things. I think it's been too successful in some ways. So we're seeing problems now with people using it as a preferred route of contact. So over the weekends, lots of e-consult requests being generated, so that an average size practice, say with about 6,500 patients, can often come in with over 1,000 requests, which is just not possible to work through. And that in there might be some quite chunky issues. And so we're working with e-consult to look at how can we direct patients to other places when they're making contact, when there won't be anybody to review that in the time period that we'd want, which is within a 24-hour turnaround. So we'll work with that, and that might result in that we have to shut the service down over the weekend, or if there's protective learning, so that that patients are directed towards either 111 or other services that are put on to meet the needs at those times, rather than sending in an e-consult, because it won't then flow through to those services that are there to pick up any urgent needs. So we're working with e-consult on how that works. So in some ways it's been too successful and too popular.
I suppose it's an education thing, really, isn't it? That and also access, in that if patients see that it's being used inappropriately, maybe they'll try and find an appropriate access to healthcare. But in the interim, we'll just have to see how it goes. Yeah. Thanks very much for that.
No problem. I mean, some examples have been a couple of cases that were relayed on one of our primary care calls with patients with symptoms for an hour or so that had put in an e-consult on a Saturday, which was picked up on Monday, but everything is resolved. So there's a lot of work that's being generated that's not adding value, if you like, because it's almost been a bit of a knee-jerk to send a query, which then, as a lot of things do in primary care, if they're not dramatic, resolved itself, but that's generated work in reading the initial query, contacting the person who's raised it, eventually getting hold, and it's all done and dusted anyway. So you just need to be a bit more optimal about that, and that work will carry on. It's a nice problem to have.
Is there a means of cancelling a request on the e-consult system?
I don't think there is. I think that once it's generated, it gets sent. I don't think the person who's generated it can go back and say, oh, it's all fine, as it were. That is, again, something we're talking with the company that provides the package about.
Yeah. Okay. Thanks very much once again, Andy. Does anyone have last questions before we let Andy go?
Chairman, yeah, Tony Williams.
Okay, fire away, Tony.
Yeah, it's a question I asked at our last meeting about Great Sankey Hub and the lack of use of 4 rooms, 2 treatment rooms and consulting rooms in the hub, because the Department of Education had not released them to health. So those rooms were not being used. I just wondered if Andy had more information, whether the education or the government, as it is, have released those rooms for usage yet.
To be honest, I don't know with that one, Tony. I think we've had a bit of pressure off on room space with everybody working more remotely anyway, so it may well be that's fallen into abeyance, but I can ask for an update and see if there's any movement on that, so that if and when we do need to get in there, we know whether we can use them. So I'll find that out for you, Tony, but I don't know off the top of my head.
Thanks, Andy.
And thanks very much once again, Andy. Thanks for your time. That's great.
Pleasure.
Okay. Thank you. Which brings us to item agenda number 7, which is Health Watch Warrington's annual report. Who's taking this?
Good evening, Chair. It's Lydia from Health Watch Warrington.
Hi, thanks.
Okay, we've supplied our annual report, submitted that, and I'll just run through some of our highlights if I can. And then also I'd like to include the slide for the COVID survey results. The full report will be submitted at the end of the week. Okay, so our first priority was from last year, 2019 to 20, was our maternity. And we worked with Warrington and Halton Hospital, and we worked with women who were using the maternity services. We held an event, and our report was also published, and there were several recommendations that we shared with the CCG, and we presented that at the Health and Wellbeing Board. Our second priority was young people around mental health services, and our young people mental health report will be published by the end of next week. And we interviewed a small cohort of young people, 49 people, and that was a snapshot looking at access to mental health services. We worked with North West Boroughs, and we also commissioned Warrington Voluntary Action, who held certain focus groups, which were structured interviews, and we also supplied some case studies as well. The report will have recommendations, and that will be shared with the CCG. Our other priority was the start of the People Panel, Warrington People Panel, and our first meeting was held in October 2019, and we've got 10 people on the physical panel at the moment, and that's a variety of people from different backgrounds. And just to add to what Simon said briefly before, we've got 250 people on the virtual panel, and that will looking to increase that as well. They are working on the work streams for Warrington Together, and that's including at the moment the integrated care teams. So that's any issues around health and social care. And we also have a member of the panel who feeds into the health forum as well to update CCG on the health side. We were lucky to receive some funding from the Big Lottery, and that assisted us with our Youth Watch service. And we are working with Warrington Youth Club. We've produced a survey on young people's views in general for health and social care, and we're looking to at least sort of 500 people to reply back to the survey, and the young people will be taking that project forward, and they'll produce their own social media, and also will recruit younger volunteers to work with that project. We did a lot of work around the NHS long-term plan, national survey, and with all the other health watches, that was a reach of 40,000 people who shared their views. We also worked in partnership with our Cheshire and Merseyside colleagues, and we produced 2 further reports for Cheshire and Mersey, and also a Warrington specific report. And our reach increased by 28% through social media, and we published 12 reports, and they are all on our website. And the reports included our interim view reports, and the Cultures Medical Centre, the Frailty Unit, to name a couple, and then the Burton Wood Access, GP Access report as well was published. And we've now produced the COVID-19 survey. And if I can just go through the slide, I don't know if you've got that there at the moment. Okay, if you just bear with me, I'm just trying to get that up. Okay, so we had about 240 replies to our survey. Actually started in the April, and this is till the end of July. And what was reported was 1% had been tested at the time, 23% had symptoms but didn't get tested, and there was 76% of people who had no symptoms and had not been tested. And the common themes where they received their information was, as you can see, sort of government.co.uk, the news, the radio, GP services, NHS, CCG, social media, Health Watch, and North West Boroughs. And we've got nearly 93% of people answered the survey, said it was clear and understandable information, so that's interesting at the time. And a negative, unfortunately, we have nearly 57% of people who answered thought that their mental health and well-being have been affected. We've also got nearly 52% of people who said that their healthcare or other conditions haven't been affected, and stating that the primary care was actually easier to access now, and I think that might refer to the e-consult, which Andy mentioned earlier. But having said that, obviously there's sort of 49% there who has been affected, and our full report will go into some more reasons why that was stated. If I can just go down to the common themes. Positive common theme was an increase in community spirit, and obviously the negative themes were there was an increase in anxiety, stress, lack of routine, isolation, lack of activity, negativity, sleep pattern disruption, and also the increase in alcohol intake. And if I can just quickly go through the demographics of that, there's 26% of male, 72% female, 2% preferred not to say. And I'd say the majority really of people who answered in that sample was 46% of age sort of 26 to 49. And we only had sort of 9% of over 65 who answered. And then I think you can see 37% 50 to 65. And again, only 8% of 16 to 25-year-olds actually answered the survey. And just to say as well that there was an 18% disability that was captured on that survey. And as I said, the report will be published by the end of this week, and we'll share that widely with everybody.
Okay. Thank you very much, Lydia. Does anyone have any questions at all for Lydia? No one at all? Okay. Thanks once again, Lydia, for that. That's very, very useful and very interesting information. Certainly the common themes, it's interesting that there's a community spirit there, but also the levels of stress and anxiety is quite concerning, I think.
Yeah.
It'll be interesting to see the full reports when they're available. So thanks once again. Thank you.
Thank you.
Which brings us to item number 8, which is adult social care and update. Is this, Margaret, are you taking this?
Oh, it's Rick Howell, commissioning lead. I'm going to sort of introduce it, but Margaret's on the call as well.
That's right.
Thanks. So a colleague, actually, Caroline Williams, had planned to sort of tell the story that's presented in the slides tonight or this evening, and is pretty well placed to do so because she's the Director of Integrated Care, which sits in that place between health and social care. But as things are at the moment, she is currently ensconced in meetings at the hospital, working on plans around discharge and stuff. So I'm going to do my best to take you through somebody else's slides. The information that's presented refers in part to the learning and in part to recovery. I think what's interesting is that the slides were sort of pulled together probably a couple of weeks ago, and as Tara indicated earlier, I think probably 3 or 4 weeks ago, we felt like we were moving positively towards a recovery phase, having seen the number of transmissions fall, the number of outbreaks that we were seeing in care settings falling, and we had some confidence that we were going to be able to, in fact, be able to restart and reopen some services that we'd had to pause or reduce or change over the last months. We're incredibly mindful now that with transition rates increasing as they are, we're once again needing to be very careful. And whilst we are applying the learning that we've made over the last months, full recovery seems a little further away. So what I plan to do was to take you through some of the things we feel that we have learned, some of the things that we feel that we've done, some of the things that we'd look to continue. And just before I said any more, I wanted to kind of reflect Andy's view, really, Andy Davis's view from the CCG before, that one of the things that we've experienced, one of the most significant bits of learning for me has been seeing the way that people have actually consistently moved towards the challenges together. And that we've seen people being creative in what they tried to do, and people have shown courage in terms of continuing to come into work and look at different ways of working, and also shown quite a lot of leadership. I've shown leadership and decision making at all levels in the organisation, whether you're in the organisation, in the community, whether you're an informal carer at home, right the way through to whether you're a chief officer in one of the organisations. So what we set out to do was 3 or 4 things. One was to try and, throughout all of this, is to keep people safe where they live. And what we mean by that, that's whether you're living in a supported accommodation setting in the community, you might have a learning disability, whether you're in a care home, whether you're living with a situation where you may be at risk of domestic abuse, or whether you may be just about to come out of hospital after a spell, to support you with your mental health. So we were looking at finding ways of keeping people safe wherever they lived. A priority to us has consistently been, that's been sort of escalated over the last months, has been supporting carers and families. And when I say carers, I mean particularly informal carers and families who've taken, in many cases, a much more active role in care over the last months, to assist people that may be vulnerable to poorer outcomes, to stay safe and well, and also significantly to support the hospital to ensure that the most unwell people can access care when they need it. They were the sort of four or five sort of entry points that we made, and to deliver those, we recognised that we were going to have to be part of a whole system response. And when I say a whole system response, just to sort of restate, that very much related to people that use services, private voluntary organisations, care providers, people that run day services, as well as obviously those other big institution settings like the CCG, hospital, and also the many public volunteers that step forward, for example, to be part of the Safe and Well service. In terms of some of the things that we did, which hopefully are illustrated within the slides, one of the primary points was establishing good communication routes and ensuring that we were both interpreting some of the requirements that were coming down and the expectations, whether that be to care homes or talking to people that use services about how they would be able to access them at the moment, and giving a mixture of daily and sort of weekly teleconferences and meetings, some of which are continuing still. One of the other things that we looked to try and do quite early on as well was to create space to listen to people. And when I say listening, I mean to create the opportunity for people to give feedback as to what they thought some of the challenges were, and how they were felt that we were best placed to address them. And summarised in some of the information in the slides, I think that is there is testimony in that to people at all levels in the organisation and in the community, providing thoughts and ideas about how we might be able to meet some of the challenges. We looked at practical and financial support, and when I say practical and financial support, that's a mixture of supporting the distribution of PPE, that's providing sort of online training in real time, even down to some simple things like appropriate ways to don and doff PPE in order to be able to keep yourself safe as a worker, right the way through to things like contingency payments that we've offered to providers in lots of different providers to help them with the extra costs of dealing with COVID. One of the other parts of that financial support is that we looked at, where possible, of combining the money that had come into the local authority via the government contingency support, along with the money that was made available via the NHS. So in a number of areas, we've looked to combine those local monies to get best value. What we've tried to do is continue with a sort of daily prioritising and giving opportunity to multidisciplinary decision making. There were a number of hubs that we established whereby teams were allocated responsibility for particular areas of work or particular need groups or service types, which has worked well. There was a provider hub which was responsible and had accountability for all of the provider liaisons. There was also social work hubs as well, where people were looking at prioritising particular areas of work. So I'll move on. So some of the consequences and challenges, I guess, of where we find ourselves now, what we thought would be the recovery stage. There are a number of issues still to work on and address. So what we're identifying is that there is considerable pressure still on family carers, particularly in the community, many of whom have stepped forward to take extra caring responsibilities. There are people that we're recognising that are feeling isolated from the support networks that would keep them well. That might be people with mental health problems, learning disabilities, people that may experience or face domestic abuse. One of the challenges going forward that continues to be the case is managing and supporting the workforce to maintain the level of momentum that they've had in dealing with the changing face of the crisis and what's required. We have to remember that the vast majority of people that are working in the health and social care sector are natural carers. They're people that want to offer comfort and support. They want to engage in people's lives. They're drawn to this area of work for those reasons. That's been incredibly challenging by doing more of the work that we're trying to do over the phone, online, and so on and so forth. And a particular recognition also for all those frontline workers who might be delivering care at home or working in care homes also, who are facing different challenges in terms of wearing PPE and not being able to engage in care as they used to previously. Our hope and ambition to be able to restart some of the services that have been paused, particularly things like day services. We're continuing to monitor. It's a challenge. We're reopening some of those, but on a smaller level than we'd perhaps wished, and focusing that on wherever possible people that may be in the most need. We're hopeful of doing more of that soon. We're also continuing to support care settings, particularly care homes that may need additional help and some financial support that have been affected by the impact on their occupancy levels over the last few months. Not least, that comes out of some of the info, we're working with the hospital at both the front and the back door, as we might call it. The front door in terms of working to find ways of providing good care and support to people to be able to stay at home or where they are and not need to go to hospital where that's safe. but also to help them to leave hospital safely as quickly and as effectively as they can, in order to do that thing that I said earlier on about being able to ensure that people with the most needs can be treated in hospital. So our experience is that the environment has continued to change over that time, and in recent weeks, children being back at school, carers going back to work, and also the positive impact that testing approaches has had on, for example, care homes, in being able to identify earlier any potential non-symptomatic outbreaks and so on, all of which are again continuing to affect our approach going forward. So and I'd like to finish really just by giving reference and continuing recognition to everyone that's been involved in working so hard over the last weeks and months. So I don't know whether my colleague Margaret has got anything to add to that, or we'll open up for any questions.
Does Margaret want to add anything before we go to the questions?
No, I mean, I think that was very comprehensive. I only endorse and support really everything Rick said. If there are questions, it may be that I can add some detail to
just before I go to the questions, on behalf of the committee, I think obviously the caring professions and the people that are even doing care as on an informal basis are very, very often overlooked, and the work that you're doing and they're doing is very much appreciated. And I think part of that, I had mixed views on the clap for carers, but I think the intention of it was appropriate, and I think the work that carers are doing across the whole of the NHS and outside, and within the caring workforce, formally and informally, is very much appreciated. So thank you very much for that. Does anyone like to ask any questions to Rick or to Margaret?
Chair.
Yep.
Councillor Wheeler.
Okay,
just a general question. A couple of months ago, at the height of the pandemic, there was a lot of concern about residents being discharged from hospital back to care homes without being tested for coronavirus. And at that stage, there were not many facilities to test, so care homes couldn't do it. And I'm just wondering, has that situation changed? And you know, is a resident discharged back to a care home without testing or not?
So I think Simon is on the call as well from the hospital and may be able to. The answer to that is not. So we've got arrangements that have been in place for some time where, whilst certainly for as long as we've had the testing capacity and that's been available through the hospital, people are not being discharged into care homes without a negative test, and work has been done wherever possible to make that that negative test as close to the point of discharge as possible, so that the individual and the care home that people are going to have the best assurance that they can that the person that's coming to them is negative. Care homes now also, on somebody moving to stay there or returning from hospital if they were living there beforehand, would commonly follow an infection control process where somebody would be in self-isolation as well, even with a negative test for a period of days, whilst that's monitored and now picked up through all home testing, which is part of a national programme. I don't know.
So I think Rick, the answer to the question is things have changed considerably, isn't it?
Chair, may I come in here? It's Simon Constable here.
Sure, Simon, go ahead.
Just to confirm for the avoidance of doubt that all patients who are discharged from hospital into a care home of any type will have a COVID test prior to discharge, and it must be negative before discharge, and there'll be a clear period of isolation, and indeed the chain of infection prevention and control is very clear, up to that point. So the system situation has changed quite considerably from the early stages of the pandemic.
Thanks for that clarification, Simon. Thank you. Does anyone?
Sorry, thank you for that. That's great.
Can I just ask a question regarding two things? One, the PPE situation, has that changed at all in care homes in particular? And secondly, there's quite a lot of staff that tend to do agency work, and they would go from one care home to another. And I just wondered whether or not that is continuing, or if there's been more of a people working in the same homes as they do on a regular basis.
So shall I? I'll come in and try and pick those up. So in terms of the PPE situation, just a further bit of context. Probably in May, the government launched what was called a national tracker, which included about 10 questions. I haven't got the list in front of me, that went out to all CQC registered care settings, which required them to update on a series of positions and how they were dealing with it, to score themselves a kind of a red, amber, green, which included, so have you got suitable access to PPE? Are you managing to limit the number of staff, agency staff that may be required on site? Are you able to cohort positive, when required, people that may be confirmed as positive? So what that's provided us with is a regular insight across all of the care settings in Warrington, which has helped us then to understand where each of them is at and the confidence in being able to deal with some of those things. That set of questions was required to be completed weekly and was connected with the national grant called the Infection Control Grant, one of the requirements of which was that care homes completed the regularly completed the questions, which included things like, there was mention of it before when Andy was talking about knowing who your medical clinical lead is. So all care homes were issued with information as to who their clinical lead was, for example. So it asked a whole series of questions like that. What we've seen in relation to PPE is the scores go from red to green, and they've certainly in most settings been green for a number of weeks. Just last week, the government has confirmed a plan to distribute more PPE free to registered settings, whether that be domiciliary care providers, care homes, or supported accommodation, and there are arrangements that are being put in place. So care providers will need to register on a national portal that will then allow them to be able to order and receive PPE. That's in the first stages, but and the expectation is that the orders on that will be limited for the first week or so, but then that will increase over time. So that's a much more positive picture. In terms of agency work, what homes have tried to do is offer overtime and different ways to keep the same staff group. Homes have created different sort of bubble arrangements in different parts of homes, again, in order to be able to limit the number of people that are potentially even moving between different parts of the home. We have seen an improvement in relation to the number of agency staff that are being used, but as the whole home testing programme has sort of rolled out, in one or two homes they may have to use agency, but what some of them have done is that they've booked a regular agency person, so they know that the person that will come in is committed only to work in their setting. So I think again we've seen a reduction in the use of agency staff that are moving between different homes.
Okay, thanks very much, Rick. Does anyone have any more questions before we move on? Okay.
Just a quick one, Chair.
Oh yeah, okay, thanks Tony.
It's around 12 months ago since I had sight of a briefing paper that identified that we need in Warrington around about 150 places for dementia sufferers to go into care. I just wondered if Rick could tell us if that number has come down or gone up. Do we still need places in care homes for dementia sufferers?
Yes is the answer. I think one of the things that we're doing at the moment is taking stock of where we find ourselves in relation to the care that's required going forward. We've obviously there's obviously been deaths across a number of excess deaths across care settings that we're looking at what capacity that there is that's left within those care homes as at the moment, but we continue to anticipate a need for particularly dementia nursing and also more complex residential dementia as well. So yes, we expect to still need dementia nursing and residential dementia care home provision, but we're taking stock as to how much we will require based on the capacity that we've currently got within our local care homes.
Okay. Thanks once again, Rick, and Margaret, thanks for your time. Which brings us to agenda item number 9, which is Warrington and Halton teaching hospitals. I think that's over to you, Simon.
That is indeed, Chair. Thank you very much. I have a very brief presentation pack to share with you, if that can be displayed, and I'll take you through that and then open up the questions if that's okay with you.
Yes, that's fine. Thank you.
So can I have my first slide, please? I know there's a bit of a delay. The first slide with the graph on?
Yes, that's right, Simon. They're on there for you now.
Right. Thank you very much. So the first slide, just as a bit of by way of introduction, shows the number of people in our hospitals, both Warrington and Halton hospitals, since the start of the pandemic in March through to the most recent figures we have for this week in September, which I'm sure members of the committee will be very familiar with, showing the very classic trend both nationally and in the northwest, where we peaked entirely as predicted with 124 inpatients on the Easter weekend, with a very slow fall thereafter, relatively low levels of a handful of patients over the bulk of the summer, and as Tara and a number of others have reported already today, within the last few weeks seen a slow but definite increase in cases in hospital, reflecting the increase in community prevalence. Next slide, please. So the most up-to-date position statement I can give you today, as of midday, is that, as I said, over the last few weeks, we've had no more than a handful of new cases of COVID-19 as inpatients over July and August, but today at midday we have 27 COVID-19 positive cases, 7 of which are in critical care, which was a peak of 24 patients in critical care with COVID-19 that we had on the 8th of April. And for context, members of the committee might not be aware that our maximum normal intake of normal capacity within critical care would be no more than 20 patients. We prepared with capacity changes, use of theatres and recovery, etc., to have 56 patients needing critical care, but fortunately that was never required. I think the most we had in total, including COVID-19 patients, was in the 40s, of 24 of which would have had COVID-19. 431 patients to date have been discharged home to continue their recovery at home, and sadly 143 patients have died. A couple of other metrics I've included there as a note of context, but Rick has already spoken about the superb work that went on with community partners earlier on in preparation for the first wave of the pandemic, meant that we, and I often talk about a surrogate or a metric in terms of long length of stay, these so-called super-stranded patients who've been in hospital longer than 21 days, a proportion of which are medically fit, but not necessarily all of them. We managed to get that number down to an unprecedented level of well below 50, and that unfortunately has crept up again to 82 as things currently speak. And the reason I include that is it is a surrogate for me in terms of our patient flow and what we're able to do in terms of cohorting of patients, etc., that gives us a little less wiggle room than we would have had back earlier in the pandemic. The other important metric that we've kept a very close eye on over the last few weeks has been total staff absence for a variety of reasons, including COVID-19. When we were doing our business continuity planning earlier on, prior to the peak of the pandemic, we were asked to model out sickness rates that could potentially go up as high as 20 or even 30%. Unfortunately, our peak was I say only, it was just over 17%, when our normal sickness absence is around and about 5. So you'll see that we did have to still cope with quite significant total sickness absence, but the total staff absence for a variety of reasons, including shielding. Next slide, please. I think it's quite helpful just to reflect upon what hasn't happened, and I suppose the caveat for that is what hasn't happened yet, given where we are, and this pandemic is still not over yet. But I think it's important, again, context to reflect upon what we were potentially considering when we were looking at media images from elsewhere in the world, particularly a relatively sophisticated healthcare system like Italy, prior to the arrival of COVID-19 into the United Kingdom. And some of the things that were really, really concerning, particularly for clinicians, as to what could have happened, but fortunately haven't happened so far. So particularly concerns about ventilator capacity. You'll recall big effort going on to build ventilators, because that is respiratory support with ventilators was at the time one of the only methods of treatment of this particular condition. But fortunately, we never ran short of ventilator capacity, nor did we ever run short of critical care capacity, or indeed bed capacity at all. Some of the concerns around having tents put up in car parks, etc., never materialised, thank goodness. Nor did we ever run out of PPE. It got close a few times, and we had to manage it very, very tightly and monitor things very, very tightly, but there was a successful mechanism of mutual aid between Cheshire and Merseyside Trust that worked extremely well, and we shared the PPE that we did have between us, so that nobody was put in a difficult situation. The other thing I would say is that some of the other concerns, particularly I can talk on behalf of the clinical body about having to make some really difficult ethical choices brought about by capacity constraints around, choosing which patients needed ventilators, etc., never materialised. And I think that meant that normal clinical practice prevailed throughout the pandemic, and certainly no clinicians were behaving as if they were just doctors. They were working within their usual sphere of professional expertise, and that was obviously something that was of significant concern. Next slide, please. So I have just described a number of things that, however, although the above didn't happen, a number of things did materialise that were challenging to manage. PPE was well publicised as being an issue that we did, as I said, needed to manage very, very closely in terms of the logistics and the supply and demand of PPE. but actually also the guidance and changing guidance and what that meant to individual clinicians and what it meant to their area did take quite some getting used to. And one of the other points that I'll make is that guidance and policies changed quite rapidly and needed us to deploy that literally on the day where necessary as new evidence came to light. I never thought I'd be an expert in how much oxygen was being used in an organisation. You'd think that oxygen supply and demand would be quite straightforward in hospital, but I think oxygen being one of the mainstays of treatment for COVID-19 for patients who are typically quite short of oxygen and need oxygen to be given either via a face mask or via a ventilator was very problematic, particularly when you were having large numbers of patients on high flow oxygen at any one time. The oxygen delivery capacity was really tested to its limits, and also, of course, this is something that is a reflection of a relatively old estate that's never really been tested with this kind of demand before. We obviously, sadly, had to get, we were managing end-of-life situations in some very tragic circumstances, really quite more commonly than we would have otherwise done, and that was very difficult, obviously, for families. It was also very difficult for staff, and indeed our palliative care team, the supportive care team, did have to, alongside critical care team, did have to expand quite significantly and very, very quickly in order to cope with that changing demand. The other issue that I've listed, but is not insignificant, is the fact that clearly this is not something that NHS staff are dealing with on their own. We are all dealing with it in terms of managing the response to the COVID-19 pandemic from a professional point of view, but we're also living with this at home too, and I think that's fairly unique in this sort of setting. It's a 24/7 job, whether you're dealing with it at home or perhaps going home to looking after loved ones or dealing with the challenges of isolation from family and friends, etc. So I think that's something that is particularly unique to the situation we find ourselves in at the moment. Next slide, please. We have, however, had a number of successes and have adapted very quickly to the challenges presented to us, not least of which is the way that we've deployed policies and guidance as it's come in, and it has come in thick and fast, particularly in the very early stages of the pandemic. We've got a very strong in-house infection prevention and control team with 3 consultant microbiologists and some infection control experts who've really worked tirelessly over the pandemic to make sure staff and patients are safe as possible. We've also had the relative luxury since June anyway of having our own in-house laboratory testing for COVID-19, both in terms of a 1-hour turnaround test, but also a rapid 4-hour turnaround test, which has revolutionised how we are able to risk stratify patients and cohort them appropriately. We recognised very, very early on that the separation of patient flows was absolutely crucial, and often that was done, particularly in the early stages, of not having as much testing as we would have otherwise have liked. But nonetheless, we did that from a clinical point of view, and it was very successful. And certainly we adopted the policy of very early escalation of those patients that were becoming ill and becoming ill quite quickly to a higher level of care, including critical care where necessary, and certainly had quite significant success with the early use of non-invasive ventilation, so ventilation with high flow oxygen that doesn't require the sedation of the patient and a tube down into the windpipe. We've also very successfully been very, very proud to be participate in a number of clinical trials nationally that have actually changed clinical practice, including the recovery trial, which came out earlier on in the summer, showing that steroid treatments were beneficial in COVID-19 treatment. Rick was talking, next slide please, Rick was talking as to where we were at when it comes to recovery, and the same is true for healthcare. Clearly what we were planning for the future, and those plans still are maintained, but clearly we're looking at it through a slightly different lens now with a resurgence. But we've got the benefit of having a coal site over at Holton, which enable us to designate Holton as COVID secure and undertake as much elective or planned activity as we possibly could, alongside some of the green pathways we already had established at Warrington to continue to undertake urgent cancer surgery all the way through the pandemic without stopping. Next slide, please. So this is very much a long-haul incident, and the issue of regional resurgence does obviously impact on the potential for recovery. I think the challenge will be particularly along realigning our usual activity alongside working with COVID-19 and winter, in the absence of no immediate prospect, certainly, of any vaccine being on the horizon to suppress the virus in that particular way. And of course, because this is a longer term issue, there is something very much around staff resilience, and as that is always an issue going into a long winter, it's particularly the case for all the reasons I've talked about before. I will very briefly, in my final slide, maybe if I go on to the next slide, please, to talk about some of the other things that are tangential to COVID-19, but not directly response to it. We've reported previously that we went live with a soft launch of NHS 111 First back on the 8th of September, before the national part of a pilot site for the Northwest as one of two trusts in the Northwest to go live with NHS 111 First. And that has been launched successfully when we're starting to learn from the early phases of this, so that other trusts can follow suit later on in the year. Next slide, please. Babies will continue to be born, and I'm very pleased to say that next month we'll be launching our new birth centre, our new midwifery-led birth centre. Unfortunately, it's been a little bit delayed because we had to put things on hold in terms of estates development from earlier on in the spring, when otherwise it would have been launched, but I'm very pleased that is very near completion now. And as I said, other things will carry on as normal. Next slide, please. Members of the committee will also be aware that we've been asking for funding to develop our assessment capacity in our emergency department, because it's too small to see the number of patients we currently see. The issue with COVID-19 and needing a separation of flows makes that even more of a heightened importance, and we've been very successful in securing funding to do that, both for now and obviously for the longer term. I think, next slide, please. We've also talked here previously about our ambitions for a redeveloped Warrington campus, and also in tandem tying that into the redevelopment of Holton, making those complementary proposals for our trust, delivering two different types of care, two very different propositions for two very different hospitals, but both of those are complementary to each other, very much part of both Warrington and Runcorn as a town, and integrated in all sorts of other ways with the provisions locally. And indeed, the next slide just confirms that we took both outline cases for both hospital redevelopments with an overarching super added case for both to our trust board earlier on in the month, and we're taking that forward through the usual process. So my final slide, I'll just leave up on slide number 14. If I leave that up on the screen, very happy to take any questions from members if required.
Thanks very much, Simon. That's a very comprehensive report, and thanks again to you and all your staff for the work you're doing at this moment. I think you also might have missed something out about the Innovation Award that you've been nominated for regarding the CPAP. Is that correct?
Yes, that's correct. So we have been nominated for the London Business School Innovation Award for the use of the CPAP machines, which are the so-called black boxes, which are used by community respiratory teams typically for patients who have breathing difficulties during sleep. And they are deployable in the relatively small black boxes that are deployed in the community. People have them at home, and one of the innovations was actually bringing those back into hospital, changing them slightly so that we never ran out of ventilator capacity. And it wasn't invasive ventilation that was found to be relatively successful in COVID-19. It was non-invasive ventilation, such as the use of CPAP. So it was one of those things where just a little repurposing of equipment that we already had access to at some quite significant scale meant that our teams never had to worry about not having the right ventilator support for patients. So that's the award that we've been nominated for, and we wait to hear about that.
And voting's still open, I believe. Is that right? So we can vote.
For the People's Award, it is. Yes, you're right.
Thanks very much. Does anyone have any questions for Simon at all? Nobody? It was
yes.
Yes. Yep. Yeah. Okay. Judith, would you like to go first?
Yes, thank you, Paul. I mean, it's great to see the investment in the ED department. I'm sure it's much needed. How does that fit in with the case for moving Warrington Hospital off the current site if that investment is going in now?
So I would suggest it's unrelated. It is. This is obviously the redevelopment of the Warrington site, whether it's a new site or a redeveloped site on the current Lovely Lane campus is yet to be determined. But nonetheless, we always recognised that that was going to be a longer game and not something on the immediate horizon. And yet we've got a busy town, a busy emergency department that is struggling to cope with the number of patients which we see. So we put a modest redevelopment proposal together to create that assessment space that is fit for the short and medium term, but is not part of the longer term agenda. And we've always been very clear that that was the case.
Yeah, thank you.
And when is that likely to be completed, Simon?
Well, in stages. Some of the work will start immediately, particularly with regards to the paediatric emergency department will start immediately. It will happen in phases for obvious reasons that we've got business continuity into next year.
Thank you. And Ian?
Thanks very much, Simon. That was most impressive, that report. Question: to help catch up on delayed elective operations, have you made any greater use of private hospitals such as Spire?
We have indeed. In fact, actually, we've had probably one of the most positive relationships with the independent sector of any trust in this part of the world, building on a already very good working relationship with Spire Cheshire. So I think off the top of my head, we've done something like 900 inpatient and day case procedures since April, and an additional endoscopy procedures on top of that. And as part of the forward plan, we have a forward plan for future use of Spire Cheshire to do even more, going into the next phase. So we've been working with them extremely closely ever since April.
Okay, thank you. Good.
Thanks very much. Anyone have any more questions? Okay. Thanks once again on behalf of the committee and residents of Warrington for your work, Simon. Thank you.
Thank you. And if I may just finally thank the residents of Warrington for supporting us so wholeheartedly. I know that it was the community spirit has already been mentioned this evening, and it really was significant and very much appreciated by all of us here at the hospital.
I think you even got a Spitfire visit recently, didn't you?
We did indeed, amongst all sorts of very different gifts that we had, including a star being named after us. I think that was possibly even more special than the Spitfire.
You might have to post or send us that the consonants or whatever where it's cited in the star.
I will do.
Thanks once again. Thank you. Okay. That brings us to item number 10, which is the Bridgewater Trust.
Thank you, Chair. It's Sarah Quinn from Bridgewater.
Hi, Sarah. Thank you.
Hi. So in terms of the work that we've done around the COVID-19 pandemic, obviously we were issued with national guidance in relation to services which we stopped or prioritised or reduced our offer. We provided a lot of support and enhancement to some of our services such as district nursing, support for enhanced hospital discharge. We contributed to the rapid response offer which was mobilised during the pandemic, which involved colleagues from the local authority as well, supporting that piece of work. We had staff deployed into urgent care to infection prevention control, and we supported the system on a number of pieces of project work, such as a redeployment panel for staff throughout the Warrington system. I think I can only echo some of the thoughts of colleagues Rick and Simon in terms of all the work that was done together as a system. I think people worked really tirelessly to be organisationally agnostic and work together for the good of the patients in the Warrington system. And I think as a result of that, we were able to really make some significant progress with the delivery of some of the services and to support the care from that perspective. We went into a period of recovery, and we've started to mobilise a number of our services again and start to deliver activity, albeit in a very different way, often using different methods of communication with patients. I think it's been a challenge in terms of our ability to deliver at the same levels of activity as prior to the pandemic because of obviously the infection prevention control actions that we've needed to take. And then starting really to get out into the community and deliver more face-to-face activity. And we've rebuilt a lot of our services, particularly around our children's offer, and we've delivered a number of catch-up vaccines and have spent a lot of time planning for the flu campaign that we're about to deliver. I think at this point in time we're in a challenged position because we're seeing obviously the second wave, and our services are under significant pressure whilst trying to support other providers to deliver the routine work that we needed to do. So I think we have seen a lot of challenges from a staffing perspective in maintaining services with the safe levels of staff in those, and we've seen similar to Simon, absence levels up to 20%. I think at this point in time, we're just balancing really how we continue to deliver activity that's necessary, obviously, to keep patients safe, but with all the pressures that we're seeing from the second phase of COVID. But I think it's been really positive, all the work that's been done as a system from that perspective. I'm happy to take any questions in relation to our response.
Thank you very much, Sarah. Does anyone have any questions for Sarah from Bridgewater? No one at all? Sarah, at the last meeting, one of the updates was that there was a CQC inspection that had been announced, but you hadn't actually had a date. Has that gone ahead?
No, the plans to step down. Was stepped down, and at the moment the CQC is currently refreshing its approach to inspection, and they're only inspecting high-risk trusts and services. So at this point in time, there's no inspection scheduled, but we're obviously in close contact with our relationship manager at the CQC.
Okay, and was there something regarding the children's services and the integration of that? Has that developed?
I think we're working on a piece of work around bringing our children's services closer together. Obviously, we have the 0 to 19s offer, but then we have the specialist children's services, and making sure that those are integrated and working together successfully, and then supporting with the strategies that are in place from a system perspective. So we're progressing that piece of work at the minute, and just really supporting the delivery of the best children's services that we can from that perspective. And I think obviously the pandemic has impacted on them significantly, with not being able to go to school and not being able to do the activities that they normally would.
I think the whole of the community services though is something which is very often overlooked. So thanks once again to you and your staff for the work that you're doing. Thank you. Thanks. Okay, which brings us to North West Boroughs. Who's here from North West Boroughs? Forgive me.
Yeah, it's Mike Kenny here representing Simon. Today
Hi,
was
Mike.
that was the trust board and AGM, so you have to make do with me. I'll highlight I'll highlight the salient features in terms of the challenges faced by us as a secondary care mental health provider during the period from March to the current position now. I'll start with workforce, if I may. The mental health secondary care services delivers care services with about 350 staff approximately. So obviously with the difficult periods of March, April, May, as articulated by Simon in his representation of the acute hospitals demands, not too dissimilar picture in terms of planning for absence. Obviously the instruction of control and command of bronze, silver and gold and business continuity plans were made by the organisation. Specifically for Warrington, we had situation reports which reflected those who were in high risk group shielding, those working from home, those who were self-isolating for suspected positive of COVID, and those actually self-isolating because a family member had a similar position. At one point, at the height of the period I'm reflecting on, we had of the 350, 141 not in work. Now, whilst the vast majority, which is about 40%, whilst the vast majority of them working from home, if you balance that with certain staff can't work from home, e.g. inpatient staff, that was probably one of our biggest challenges. So in terms of redeployment from our mental health community services, where we could to support our inpatient services and services that we would say were urgent response, which would be our home treatment and assessment services, was obviously a big challenge. I think one of the salient features for us was at the beginning, April and May, our inpatient occupancy dropped to 65% to 70%, which is the lowest it's been in my 14 years with the organisation. And actually, if you was to try and make a comparable, then that possibly fits with the roughly the split between detained patients and patients who are informal or voluntary, which is roughly 65-35. So we managed, at the point of the trust actually shut a male ward, closed a male admission ward. Obviously, with the workforce demands being it was important that we managed that as best we could. And actually, the ward that was closed was a male admission ward in Warrington, which was Austin ward. That didn't affect Warrington patients receiving the service, but we managed that very well, and we only actually ever admitted 8 patients during the period it was closed. It was closed roughly for 6 weeks. 6 to 7 weeks. Now that is complete in contrast to what our demand became, which is reflecting a national picture. So mid-June, probably July, August, September, our occupancy levels went over 100%, which is a national picture, with acuity that I've not seen for a long time. I'd split them into 3 groups, if I may. The first group would be those who are known to our services and have relapsed to the point that they required quite a high level intense need to be treated in inpatients with presentations that were difficult to manage. The second cohort, I would say, are patients with a comorbidity presentation, i.e. mental health problems exacerbated by the use of illicit substances, particularly drugs. And then I think the third cohort, a much smaller proportion, because more patients in this group would have gone to primary care. But those patients we've never met before, a new group of patients who are people who would have lost jobs, not been able to attend funerals, not been able to do the things that we often take for granted. Although that's a small number, there is a new group of patients we've never met before. As an organisation, like many of the mental health providers in the northwest, if not all of them, we've had to seek private beds. So as we stand now, we've used up to 20 private beds. In Warrington, we've done quite well. I think our greatest period was towards the mid to end of August, when we had 5-6 patients in private accommodation. But we've established links with those private establishments and bought beds to block them, but other trusts were doing the same. So I think that was a big, huge challenge, and still is, in terms of reflecting probably the opposite to what happened in the acute hospital. Quite rightly so, all the attention for March, April, May was on the acute hospital. We were the opposite. We were quiet. We're having our demand now in July, August, September, as we add to winter months, and obviously the trepidation is moving to a lockdown when it's dark, and I'll be very pragmatic. It's possibly easier to lock down when the sun shines and less so when it's dark at night. So that'll be one of our reflections. Then the other salient feature for us, we introduced as an organisation something we call the CERG, a Clinical Ethical Reference Group, which was used to support the control and command establishment of gold, silver and bronze, but was to advise gold. And this was purely set up to sift through and give a steer from clinicians on the deluge of national guidance that was coming in. I noted one of the councillors earlier in the day talked about clarification. Yes, lots of national guidance came in, some of it at a great volume. And I think things that we often take for granted, like visiting, obviously was stopped, and when we could reintroduce that, I'm not suggesting visiting is taken for granted in the acute hospital, but there's something about being detained under the Mental Health Act and not being able to have contact with a loved one. So it's how we reintroduce that. Section 17 leave, which is particular to our hospital. This is again patients that were detained under the Mental Health Act being allowed to have a period of leave, whether that's at home or a walk around the grounds, etc. And how we managed that in a safe way was a challenge. And we also introduced, which is for a secondary care mental health trust, was unique, what we called enhanced physical health teams. And whilst we make no comparison to the skill set of our acute colleagues, for a secondary care mental health trust, this was 3 teams who, with junior doctors and people who had physical health training, to in reaching towards, as our COVID cases increased, the pathway was still to send those patients at a point where they became ill, which was beyond our capabilities, to the acute hospital, but it was just to help take that pressure off the acute hospital. I would say that was one of those things that worked well. And I think the last salient feature for me to highlight would be the implementation of the crisis line. It is a National Health England strategic target that all mental health trusts in the UK, or England and Wales, would have a crisis 24/7 service by March 2021. That would include a 24/7 crisis line. It became a challenge because they wanted us to do it in 9 days. So we had what should have took us a year. They asked us to do it in 9 days without any resource, at a point which I fully understand and support. Obviously, if patients are self-isolating and not getting the contact with mental health services they should be getting, then we need something to help that. The difficulty for us is it had to be done by the 14th of April, and we were doing it at a time when we had more staff off and with no extra resource, but we managed it by, again, redeployment, etc. To give you a little breakdown, if you're interested, very quickly, our crisis line between 14th of April and mid-August for Warrington residents had 466 contacts, roughly split, more or less 50-50. It was 52% female, 48 male. The greatest use of it in terms of age range was between 40 and 64 years of age. Actually, the least use of it was our younger elements, which was 18 to 24. The peak periods are actually lunch till 6 p.m. And then after that, 8 o'clock in the morning till lunchtime. The actual after midnight is the lowest use of it, which is roughly about 10%. outcome of the 466 people who contacted the crisis line from Warrington, about a quarter were referred to secondary care mental health services. So 3/4 were either signposted back to GPs or primary care or other support agencies. And I think probably the only salient feature about that is that the greatest referral was self-referral. Which accounted for 70% of all contacts actually were self-referrals. It was actually minimal referrals were done by other agencies. So I think if I was to reflect in terms of a secondary care provider, what went well, www, I think the IT usage, none of our services ever shut. They all remained open, every single one of them, though obviously they became an amalgamation of what we offered face-to-face and what became the use of, IT, video conferencing, etc. And obviously we had to get that balance right. Routine appointments became more video conferencing, but we obviously kept inpatients going, urgent response, home treatment, assessment. I think the recovery and restoration plans were now in. So we submitted our business continuity plans in April. Therefore, we need a recovery and restoration period. The restoration period's June to July. Our recovery period is now. I can say with clarity that we are now up to 90% of the activity levels that we had pre-COVID. So we're more or less back on track. Obviously, our trepidation, as I mentioned earlier, is if we enter into a second wave, which I personally would think would possibly potentially be more difficult if it's anything like the first area, because of those winter months are generally, for mental health reasons, more challenging traditionally in terms of inpatient occupancy and demand for services. And I think if, what I call my EBI as the Assistant Director for the Borough of Warrington, which it means even better if, I think we need to reflect and just check, did we get our recovery model correct? i.e. the team with the biggest amount of patients is our secondary care mental health community team, which has somewhere between 800 and 900 patients. Did we get that bang on right? Because some of the things we've seen in terms of patients we've not seen in inpatients for a while relapsing, did we get our RAG rating right? And I think we need to look at that as a learning thing. And I think, generally speaking, there would be my updates. I'm happy to take a question if I can answer it.
Thanks very much for that, Mike. It's very comprehensive and interesting and disturbing at the same time, I think. Anybody have any questions for Mike at all?
Chair?
Okay, Judith, go ahead.
Can you hear me?
Yep.
Thank you very much for that. That was really, really interesting. And the question I was going to ask, you touched on in your last piece, the really big increase in your existing users and also the ones who came in with particularly drug problems. That spike, was that, do you think, down to less contact from the community practitioners who would be looking after them normally? I mean, I thought that's what you alluded to.
Yeah, I
that
think it would
service
be safe to
declined
say,
and they relapsed as a consequence.
Yeah, I think it's safe to say that without a true evidential base that has been audited and checked, I think it is reasonable to say that if ex-patients were getting visits once a week or once a fortnight or once a 3 weeks or once a month, depending on their clinical need, and actually all of that changed, did we get the right cohort to match their need? And I think it's reasonable to say that in some cases that those patients may not have got a service under normal circumstances that they would have got because of the demands. And actually that's a picture we've seen nationally. I personally, with 35 years behind me, I personally have never seen a level for a long time with a level of acuity, and I describe acuity of patients being really poorly on some of our inpatient wards, which is reflected in Merseycare in Cheshire and Wirral and other trusts as I have networks there, and actually secondary care mental health trusts in the northwest block purchasing private accommodation because of the demand. And as I said, that's also been enhanced by a new cohort of patients we've never met before, and clearly a group of patients who may have used or have used substances as a coping mechanism of being in some level of lockdown. It's a big learning curve for us all.
Yeah, thank you.
Thank you. Any more questions for Mike? Couple of things, Mike.
Yeah.
I just think I'm wondering whether or not there's any primary prevention that's able to be implemented, because clearly lots of people are struggling through lockdown in the summer months. This is going to go on for a significant period of time. It sounds like your crisis line is very, very busy, and people are identifying themselves that they've got an issue. And there seems to be quite a lot of new presenters with lost jobs and depression and other things. Is there anything that could be instigated that would enable the tsunami or potential tsunami to be reduced slightly?
Yeah, as I said, for me, that was what I mentioned under Even Better If. I think the review of our community model in terms of our community service and our connectivity with primary care, people who've lost jobs, who've been furloughed, who've not been able to say goodbye to loved ones, may have missed births, christenings, whatever, some of the milestones that help keep us well, connectivity with friends even. I think that those patients traditionally would probably be started at a lower level mental health. So the connectivity with our IAP services, mental health matters, primary care, etc., I think needs to be more joined up should we head in towards a second wave or a second spike. So, because we're going to see a small element of those patients, but how do we work with primary care in terms of making sure that's safe? We know in terms of depression, etc., that increases in darker and winter months. It's traditionally an area that is difficult for us. So in terms of our community model, based on what I've said, is putting more resource into that, not just because we've kind of gone down the crisis intervention route with the crisis line, etc., but the crisis line's one thing, it's the response to that along the lines of the preventative stuff, which I think where we come in and need to pay particular focus in terms of secondary care, being able to flex, to not wait for somebody needing service and get in there, working with our GPs, etc. And that's where I think we will be focusing along with all the other boroughs in our organisation over the oncoming months.
And we were also discussing social prescribing earlier, and I think that also has a part to play in this.
Huge connotation for mental health.
Yeah, it really could be very useful, and I think by the time they've got to the crisis line, I suppose they're in crisis, and if we can get social prescribing in place and get people to be aware of the things that are on offer with that, then that might be helpful as well.
Yeah, absolutely. I can agree with you, Mo.
So last time, was there a CQC report that was due to be shared with us?
We had our CQC visit last year, so I'll check with I don't remember it because I think the last meeting was February, wasn't it?
Yeah, it was a long time ago.
So obviously we were graded, but there's an update on that based on the fact that we recently, so this would be my any other business, which has connotations based on what you've said. There was sadly 2 inpatient deaths in Holton in June, July, which meant that the CQC visited Holton at the Brooker Centre, which meant they reviewed the safety domain of the care that we deliver and downgraded that safety domain for all adult acute wards, even though they only just visited Holton. The incident was only in Holton, to requires improvement. That's not affected our overall rating in terms of good for all our other services and the overall rating of good for the trust, but that has been a change. So I think in terms of me checking what you require in terms of an update, that would actually be an add-on. So, so it's actually technically changed. It's been that long since we met. So what I would have delivered is what the CQC report, which actually gave us good and in particular highlighted what a Warrington ward, which was Kingsley ward, which is the organic lambs ward, as to examples of excellent practice. But what I'll do is I'll speak to our governance department and make sure you get a written update in terms of what I've just said and the original reports, which I would have presented probably around about April and May had the world not changed.
Okay. And is there any update briefly with the
Merseycare? Yeah, okay. So just in terms of the Merseycare NHS Foundation Trust acquisition, it is still proposed to be on target for the 1st of April 2021. Basically, the strategic case for the trust was presented to NHS England for consideration in July. We received formal response confirming that the proposal was approved. So basically, we are still moving towards that date of the 1st of April 2021. Obviously, there's an internal due diligence and NHS assurance process, which obviously has to take into effect the ongoing COVID pandemic. So basically, at the beginning of September, they launched 8 work streams, which is from governance through to quality through estates, procurement, workforce, etc., which is Merseycare and North West Boroughs working together in terms of representation from both organisations to support the transaction, and it's still technically on track. Fingers crossed what happens to the country over the next few months to be delivered by April 2021. So all our staff will TUPE over, with the exception of course Wigan, where they will TUPE over to Greater Manchester Mental Health Foundation Trust.
Right. Thank you very much for that. And thanks to staff, I think the levels of sickness that you had and still maintain services are pretty incredible.
Yeah, that's why I started with workforce, probably our biggest challenge.
Yeah, and continues to be, but thanks very much and keep up the good work. Thanks very much, Mike. Okay, I think it's NHS England. Anybody with us, Adam?
Not that I'm aware, Chair. I don't think we've got any representative from NHS England this evening.
Okay, thank you very much. Which brings us to the work programme, which is at the back. I don't tend to go into this in great detail at this moment in time, because we've got some standing orders and there's a couple of things that are still outstanding, such as the Eastern Sector Cancer Hub, which we will come back to. But I think we'll probably have some further meetings and come back to that. But we do at the next meeting on the 5th of November have some agenda items already. So without further ado, I thank you all very much, and thanks for your time, especially our invited guests, and I'll see you next time. Have a safe journey home. Thank you very much. Good night.
Thank you. Thank you, Jay.
Bye.